I'm here to talk about intrarenal pressure monitoring during FANS flexible ureteroscopy. And FANS is flexible and navigable access sheath, which is a term coined by Dr. Vineet Gohar. So thank you so much for this invitation. And you'll see throughout the presentation that probably Vineet should be giving this instead of me. And I put his picture up many times for all of his work and hard work. So these are my disclosures, and the relevant ones are highlighted there with Boston, Olympus, and Stord. So I'm actually not going to talk about the Calixoscope because it's not approved in Canada, but it is a suction access scope. In 2022, the LithoVue Elite was the first, we were the first ones to be able to use it in Canada, both Naeem Bojani and I. And I wanted to share some data that we've published on it. And this is the only intrarenal pressure monitoring scope that is currently available in Canada. So this is me zeroing it at the beginning under hydrostatic pressure. And it takes about maybe 5-10 seconds. Once it verifies that pressure, then you're able to put it into the patient afterwards and then get started, and then it'll give you pressures there. Now, we published on our first 50 cases in the world that we used LithoVue Elite, and we wanted to measure what the pressure was, because before this we didn't really know or couldn't routinely measure it without having difficult things putting up with their catheters. And I think the things you want to kind of know here is that the median intrarenal pressure is 28.5 millimeters of mercury. This is without an access sheath, this is with an access sheath, and I must note, this is without suction. Okay, so remember, this is the baseline, 28.5, and this number will come up later. And in general, around 174 millimeters of mercury in terms of the maximum. When we look at this distribution of the amount of intrarenal pressure over time, we can see that 92% of the time was spent below 60 millimeters of mercury. And 73% of the time was spent below 40 millimeters of mercury, which is somewhere where we agree from previous old studies that that's probably where things are safe. Now, when you do get this measurement, this is kind of what the measurement output looks like. It's measuring it at 4 times per second. And for instance, the maximum is 300. So if you touch tissue and other things like that, you do get some artifact. So a lot of these pressure tracings have to be cleaned up and really looked at. So again, you know, it's very clear where the pressure is here, that it's about at 100. But then sometimes when you get pressure tracings like this, it's really hard to tell when you're touching things and it's spiking up quite a bit. So there is a bit of challenge in measuring what the actual renal pressure is. But what we have done is looked at the amount of pressure over time, and we think that that's something that's important. The 4 things that we thought were important were race. We found that Asian ureters had higher pressures. Placing a simple ureteral access sheath without suction decreased it. If the patient was pre-stented, it was lower. And clinically, if we thought there was a tight ureter, just when we were inserting the ureteral access sheath, we also thought that these patients had a higher renal pressure as well too. I want to just give you a case here. This is a young 25-year-old male who was very, very muscular. This is not suction. And we put in a 35 centimeter access sheath, but his ureter was so tight we couldn't get it into the kidney. So it is just in the distal ureter. And you can see here, we're going to go up above into the higher areas here. And you're going to see that the pressure is over 200 actually. At one point it is 193. It's well over 200 during this whole time. When it is high, what we would do was take off the irrigation. You can see me taking off the irrigation there because I was quite worried. And then I would put in a catheter, or not a catheter, excuse me, a syringe to actually go ahead and try and suction things out. And then when we suctioned things out, it went down from 212 down into the 30s, but we couldn't get it below. And at this point, we just decided to go ahead, even though the pressure was over 200. The patient did not end up getting an infection, although we did place him on antibiotics, which is not my usual routine. But knowing the intrarenal pressure, I did change things a little bit. Now, before this, we wouldn't know what the intrarenal pressure was, but now with all these new scopes, we certainly can measure it in every case and know it in every second. And Dr. Molina already showed how to insert this and that how we have the trumpet valve. So I just want to show another case. Now, this is with the suction access catheter. With the suction off, it was somewhere in the 40s or 50s. And then when you get the suction on, it goes down to about 5 or even 1. So you can really, really lower the intrarenal pressure with suction ureteral access catheter that goes right up to the kidney. And what this doesn't show too is that sometimes when you go up into the kidney and there's all that old urine that looks cloudy, you can also remove that as well too, which is very helpful. And I think that's also going to result in decreased infectious complications. So this is the first of the many papers I'm going to show of Dr. Gohar that he has worked with many people, and I've had the privilege of working with him on this, and Steffi as well too. And this is something that Wilson has already talked about as well too in this paper. And what it does show is that it keeps intrarenal pressure down. And there's all these other things too that while you're lasering, you can basically clear out those small pieces of dust, and you can then identify where the larger pieces are. And I think this replaces a lot of cases where you would either do mini PCNL or PCNL. And this video kind of shows how to use it. In order to get it into the lower pole, the better way is to put your scope where you want it, and then advance the ureteral access sheath, the fans, over it. It's really hard to manipulate it with the scope and the sheath in there, but if you manipulate your scope first, then you can move your sheath over top of it. So this is Dr. Naeem Bojani from University of Montreal, and this is our second one. So the first one we did using LithoVue Elite, the first 50 in the world, just looking at pressure. Now we're doing it using fans. So first 25 patients, we use Clearpetra, we use the LithoVue Elite. Now, unlike Wilson, who set his pressure at 150 millimeter mercuries in, we actually set it at 250. We found that we actually could do this quite routinely, and we placed our suction at 150 millimeters of mercury. And most of the time, almost 3/4 of the time, we could actually put our fans tip right to the stone. And what we found was, remember, 28.5 was the median before. We now found that the median in these 25 cases was actually down to 22, and this is significant. And before, it was 73% of the time we were down less than 40. We're now at 76% of the time less than 40 millimeters of mercury, and really only a very small amount of time between 80 to 100. The other thing that was significant was using the 1214 Clearpetra versus the 1113. The 1214, the larger Clearpetra access sheath, decreased the intrarenal pressure more than the 1113. But that does come at a little bit of a price, because it was much easier to insert 1113, which basically went into all patients, whereas sometimes the 1214 had to be downsized to an 1113. So the question is 29 millimeters of mercury enough to get it down, or do you need the 14? But you have to balance that with the fact that some of the larger access sheaths may cause a small split in the ureter. So in these 25 patients, what did lower the pressure? Certainly the 1214 access sheath. Again, patients who were pre-stented, and interestingly, patients who were on alpha blockers preoperatively, or if you had a ureteroscopy within 5 years on that same side, your ureter was also larger and able to decrease the intrarenal pressure as well too. So does that size matter? And this is something that was answered actually, and this is sort of the opposite of what we found. And again, Vineet and Saeed bin Hamri looked at smaller ureteral access sheath with suction, compared the 10 French one versus the 12 French one, and actually found a higher stone free rate in the smaller one in 10 French. And this is probably because it was easier to manipulate, and to move into different areas of the kidney because it was much smaller and probably did not inhibit the deflection of the ureteroscope as much as the 12 French one. So again, this is a really nice systematic review, senior authored by Dr. Gohar, and they looked at 21 papers, and the reduction of intrarenal pressure was associated with lower infection rate. And they found a difference in stone-free rate, particularly if the stones were 20 millimeters or greater. And I think this is where I really find it. Now I'm doing less PCNL and even mini PCNL because now we can use the suction access catheter to do RIRS and suction out all of that dust while we are doing ureteroscopy. This systematic review also found reduced post-op complications. So in conclusion, really you find better vision with less dust. It allows the visualization of remaining stones. It certainly decreases the intrarenal pressure, and you can treat larger stones using ureteroscopy. Trapping the stone in the ureteral access sheath like Dr. Molina showed reduces the retropulsion. You can laser inside the sheath, which I think is also a bit safer because then you're not lasering the kidney and get those errant laser strikes. And Dr. Traxler and I have been a bit concerned about that in terms from some other lasers that are very high power, high frequency. There's probably a better stone-free rate, particularly in stones greater than 20 millimeters, and it may decrease operating time and definitely decreases infectious complications. So thank you again for the invitation. I invite everyone to come to the World Congress of Endourology and Technology this year in September in Phoenix, Arizona. It's our biggest stone meeting that we have, and we do invite everyone there. Thank you very much for the invitation.